All right, welcome to this high-yield microbiology masterclass. If you're an MBBS student gearing up for clinical rotations or board exams, you are in the exact right place. We're going to take some incredibly dense microbiology notes and translate them into a clear, logical, clinical diagnostic journey. Forget the rote memorization. By the end of this explainer, you're going to see exactly how the shape, staining, and structure of a bug completely dictate its clinical presentation and ultimately how we investigate it.
So here's our game plan for today. We're going to hit the rules of bacterial investigation, then tackle atypical and intracellular bacteria, move on to the gram-positive cocci, check out spores and gram-positive bacilli, and finally wrap it all up with gram-negative cocci and bacilli. Let's get right into it.
Part 1. The rules of bacterial investigation.
Okay, so the absolute golden rule here is dividing your bacteria into typical and atypical. Typical bugs, they're your standard players. They take up a gram stain beautifully. And for those, your go-to investigation is always a culture. But atypicals, like the ones totally missing a cell wall or those sneaky obligate intracellular bugs, they just won't grow on a standard culture or take a gram stain. So what do? We shift gears to serology. We're basically hunting for the antibodies the patient's own immune system made against the bug.
Now, think about being on the wards. When you order a culture, you've got to know when that result is actually coming back, right? Typical gram-positive bacteria are usually going to culture within about 48 hours. Gram-negatives, though, they take their sweet time, up to 72 hours. Seriously, lock those timelines in your brain. You'll need them when you're trying to figure out if a patient is responding to their antibiotics.
And speaking of timelines, here is a massive, absolutely crucial definition for your exams and rotations. A hospital-acquired infection, or HAI, is strictly, and I mean strictly, an infection that hits after 48 hours of being admitted, or if the patient used any medical facility in the last 14 days. If they spike a fever at hour 24, that's community-acquired. Hour 50, boom, hospital-acquired. And suddenly, your whole list of suspected bugs and your empirical antibiotics change entirely. Moving right along to Section 2, atypical and intracellular bacteria. All right, let's break down these weird cell wall-less and thin-walled bugs. First up, Mycoplasma pneumoniae, which notoriously causes atypical pneumonia. Then we have our thin-walled spirochetes. Treponema pallidum is the classic one here. It causes syphilis, and you're going to have to differentiate that from other genital ulcers clinically. Oh, and don't forget Leptospira interrogans, the bug behind Weil's disease. Remember our golden rule from earlier? Because they lack that standard wall, serology is your best friend here.
You know, it's wild just how much global disease burden these atypical bugs actually cause. Take the obligate intracellular bacteria, Chlamydia trachomatis. It causes an eye infection called trachoma, and trachoma is literally right up there with cataracts, vitamin A deficiency, and senile macular degeneration as one of the leading causes of blindness on the entire planet.
Over in the Rickettsia family, we've got Coxiella burnetii. This one causes Q fever, which is another atypical pneumonia. Fun fact, the Q stands for questionable fever because back in the day, the bacteria was totally undetectable until we figured out serology. And rounding out our atypicals, we have the Zeal-Nielsen or ZN-stained mycobacteria. These acid-fast bacilli are the heavy hitters causing tuberculosis and leprosy.
Okay, Section 3, the gram-positive cocci. Let's track how Streptococcus invades the body. It usually sets up shop first in the oral cavity, causing acute pharyngitis. From there, it's kind of like a crossroads. It can ascend, moving up to cause acute sinusitis or acute otitis media, or it can descend. And honestly, if it descends, well, that is exactly where things get incredibly dangerous.
Yeah, if that strep goes down, you are looking at severe consequences. It can hit the lungs and cause typical pneumonia. Worse, if it breaches the blood, it starts multiplying, releasing toxins, and you get septicemia. From the blood, it can seed pretty much anywhere, into the meninges for meningitis, into the joints for septic arthritis, or straight onto the heart valves, causing infective endocarditis.
But strep doesn't just stick to the mouth and internal organs, it loves the skin too. As a future clinician, you absolutely have to know the difference between two major skin infections. Cellulitis is an acute inflammation of the skin and subcutaneous tissues, but it has these diffused, blurry margins. Erysipelas, on the other hand, stays in the upper subcutaneous tissues and has super sharp, well-demarcated margins. Literally just spotting that clear edge makes a diagnosis for you.
Now, let's look at Staphylococcus, our other major gram-positive cocci. With staph, you're really looking for distinct clinical visual hallmarks. Take impetigo, for example, super common in kids around the mouth.
It starts as delicate vesicles that rupture and leave this classic golden yellow crusting. Then you have a carbuncle. That's a deep infection involving multiple hair follicles, and it's basically a hard, swollen area with multiple pus-draining sinuses. And sometimes these localized staph infections go systemic. Staph can actually pump out an epidermolytic toxin that causes staphylococcal scalded skin syndrome, or SSS, usually in kids. The toxin sets off this massive, widespread skin inflammation, and layers of the epidermis literally just peel off one by one. It leaves the patient with what we clinically call onion peel skin. It's as intense as it sounds.
All right, shifting gears to section 4, spores and gram-positive bacilli.
So spores are essentially bacterial survival pods for extreme stress. The big spore formers you need to commit to memory are Clostridium and Bacillus. Clostridium perfringens is the nightmare behind gas gangrene, and Bacillus anthracis, that's the infamous biological weapon causing wool sorter's disease, which people traditionally got from inhaling spores often affected cattle wool. On the flip side, for our non-spore formers, you've got bugs like Corynebacterium, the cause of diphtheria.
Okay, listen up, because this is a massive, high-yield board fact. Clostridium difficile, a spore former, loves to overgrow when broad-spectrum antibiotics wipe out the normal gut flora. This causes pseudomembranous colitis. Now, the absolute drug of choice for these anaerobic bacteria is metronidazole, also known as Flagyl. But here is the catch. For pseudomembranous colitis, you must use oral metronidazole. Why? So it physically stays in the gut lumen to fight the infection where it's actually happening.
Let's test this with a classic clinical vignette. Picture this. A 3-day-old boy is brought into the pediatric ward. He's got a fever, neck stiffness, and fits. You take a history, and it turns out his mother is a huge fan of eating dairy products, specifically soft cheeses. Based on how we classify bugs, what's your diagnosis here?
Did you nail it? The diagnosis is listeriosis. This is a form of neonatal meningitis caused by listeria. Listeria is a non-spore-forming, gram-positive bacillus, and it absolutely thrives in unpasteurized milk, butter, yogurt, and cheese. In a healthy adult, it usually does nothing at all. But in pregnant women and neonates, it is totally devastating.
And finally, bringing it home with section 5, gram-negative cocci and bacilli.
Let's talk about the enteric gram-negative bacilli. These are the familiar faces like Pseudomonas, E. coli, and Klebsiella. When you look at their disease spectrum, they are overwhelmingly the culprits behind urinary tract infections, nosocomial, meaning hospital-acquired infections, and community-acquired pneumonia. E. coli alone is a massive driver of UTIs and acute gastroenteritis. And Salmonella? That's the bug behind enteric fever, which most of us just call typhoid. Then we have the non-enteric gram-negative bacilli. These include some seriously heavy hitters from history. Yersinia pestis, that's the plague, the literal Black Death. Bordetella pertussis causes whooping cough. And Haemophilus influenzae is a huge one for the respiratory wards, being the second leading cause of typical community-acquired pneumonia.
Well, we have covered a tremendous amount of ground in this explainer today, from the atypical wall-less bugs that force us to use serology, all the way to tissue-invading gram-positive cocci, resilient spore formers, and those diverse gram-negatives. As you take these concepts into your board prep and out onto the wards, I want to leave you with one final thought. Every time you see a patient, ask yourself, how does that specific clinical hallmark, whether it's onion peel skin or a sharply demarcated rash, point you perfectly back to the bug's microscopic classification and ultimately to your definitive investigation? Keep making those connections, and I promise you, microbiology will become one of your sharpest clinical tools. Thanks for hanging out with us, and keep studying hard.